Hey, everybody, Compliance Guy. It is Monday, the 10th of July in 2023, and we are live right now here for our Monday Coding and Compliance Roundtable. So excited to be here with I almost said the entire team, but I'd be lying because we are without Christine Hall, who I know is giving a presentation today for another organization, but we do have Stephanie Howard, Paul Spencer, Terry Fletcher, and Scott Kraft. So um, I know it feels like God forever since we have uh, been on the air together. And the truth is, I think it's only been 2 weeks or something like that. I know, Scott, you were out roaming the country doing your baseball park tour and
That's
some other
true.
things. And
I got to see the
Terry was
rarest.
in, yeah.
I was going to say I got to see the rarest thing imaginable. The Yankees actually won when I was there.
Well, even more rare is the fact that the Red Sox have won 8 out of 9 games, and they've done it without Houck and Sale and Whitford and some of the other ones. So we'll see what happens. Baseball season's getting interesting. We're into dog days of summer for those of you who are sports fans, and soon the October will be upon us, and that's when all the real magic happens. So we'll see what happens. Terry, I know she's been hanging out in Napa Valley and roaming around, doing some winery and vineyard tours, and getting her sip on. And Paul's been in Wisconsin. Did you get a new car? Because I know the Yaris. We had to say goodbye to the Yaris.
Yeah, Tonto is no more. After 258,000 miles, he was destroyed by an old lady running a red light.
All right. And Stephanie Howard, I got a chance to hang out with you up in Knoxville, Tennessee, about 3 or 4 weeks ago, which was an absolute treat and delight. And that was the first time. So I have an administrative assistant, Stacy St. Pierre, and Stacy, I think, has been with me. It's terrible. I think Stacy has been with me for 5 years, maybe 6 now. I got to check. I'm terrible about that. And when we were out to dinner for the very first time, and I thought I knew everything about Stacy, I found out that my administrative assistant is actually a rocket scientist.
You didn't know that.
As my whole team is shaking their head yes, I'm sitting here going, "Wait, what?" So yes, Stacy St. Pierre, for those of you who have ever had a chance to chat with her, she is actually formally educated, has all the degrees, and she is a rocket scientist. Why she works for me? It has to be because I'm a great boss. I don't know, but I can't figure it out. All right. So, to each and every single one of you who's tuned in, logged on, and just decided to hang out with us for a little while during the lunch hour here on the East Coast and breakfast hour on the Pacific time, thank you so much for taking time out of your day. We greatly appreciate it. So we have a great conversation today. Let's go ahead and start off with what I think is a critical compliance issue, and that's querying physicians when it comes to coders or auditors reviewing a provider's documentation and believing that the documentation either supports a higher or lower level of service when we're talking about evaluation and management services, or they believe that what was documented as a procedure and what was selected as a code set doesn't match. So, who wants to be brave and take the first plunge into the ice bath? Terry Fletcher.
Yeah, I know. I was going to say I will. Why not? Since I help out with some topics sometimes. So, for the listeners out there and for everybody's watching, this is more to kind of let you know that we're kind of feeling your pain here on certain things when you just aren't sure should you code it or should you extrapolate it from the record. When is the appropriate time to query a physician? When isn't? And believe it or not, there are different rules for ICD-10 codes, so diagnoses, versus CPT codes. So first, as we dive into ICD-10 codes, they're in the general rules and guidelines for ICD-10 that not everybody reads. So you need to kind of get a hold of those. There's 118 pages of them. Around page 15, 16, 17, it talks about when you can actually, as a clinical person that isn't the physician, can they pull something out of the record if the doctor said unspecified or didn't give clarity in the record? One thing is laterality. So if there's something in the record that says patient presented with left knee pain, left knee pain, left knee pain, and the doctor then gives you a code that says unspecified knee pain, which I know that would bug everybody. That would bug me too. And you need to educate them to be more specific. If it's in the record, can it be pulled out of the record? Yes, but be clear, because it means that another clinician can actually do it. So it could be a nurse, an RN, a mid-level provider, even a medical assistant. Just it has to be a clinician that can give that to the coder. It doesn't say it can be coders. So we can get it from another clinical person, but make sure you read the fine print. And then also in that rule, it says codes for unspecified side should rarely be used. So that's a direction also to whoever's reporting the codes. And then they talk about, documentation other than the provider who's legally responsible for the patient's information and medical record. It goes on to body mass index. If it's in there, you can pull it out. Depth of non-pressure ulcers, coma scale, stroke scale, social determinants of health, that's big because we know that can affect the level of service on certain things, and also where they go as far as point of service in the hospital or point of care in the office, trying to make sure that they get what they need, blood alcohol levels, and then under immunization status. That was actually added this year. So in ICD-10, there's actually clear guidance on when you need to query and when you don't need to query. So if there's any confusion on something, obviously you need to query a physician, and then I'll turn it over to another panel person here, because one of the things that we'll find with the physicians and providers, if you query too much, they're going to ignore you. Everyone, they'll just say another email, another email. So it's kind of like, in my opinion, disciplining a child. If you get mad at them and discipline them every single time for every little thing they do, pretty soon they're just going to keep getting in trouble because now they can, get attention. They're like, you're going to get mad at me anyway. Well, for our providers, our physicians, we want to make sure that we are only querying when it's absolutely necessary. That way, when they get an email from you or they get a communication from you, they know it's important. They know that they haven't heard from you in a while, or it's something that you really need to have addressed. So just on that part, I'll turn it over to Scott and see what he has to say about that, what you're finding.
I think that's right on point. My concern with the query process, I think when well done, it's a great opportunity to enhance provider education. It should be a component of provider education. It should be utilized for key issues to prevent recurrence. One of the things that I think about a query process is it's an internal um, workflow that's designed for certain reasons, right? And it's really about who's accountable within an organization for making certain decisions, what those decisions are, and how to make sure that we're not essentially creating compliance risks or resulting in what I think the providers dislike the most, which is repeated queries for the same issues, or the inability or the paralysis of not being able to make a decision without bringing the provider into everything. I've talked to providers before who see queries in the same way they see this litany of things that they find themselves doing at the end of the day that they don't, in their minds, get paid for, whether it's calling in prescriptions or dealing with individual patient issues. And I think the last thing that the provider wants to do is open up his or her email box every day to 11 or 12 queries. So I think, to build on Terry's point a little bit, although I don't know that it needs that, I think queries should be focused on important and key issues. There should be parameters for them, and there should be an emphasis around, is there a point of provider education? And frankly, that includes other aspects of the practice, right? So, one of the things that I worked with a client in the past was there were a number of queries going out, as it turns out, related to laterality. And the issue was that the provider felt like her ICD-10 list that she was selecting from, she couldn't find the right laterality. And she basically said, I got a busy schedule. I don't have, all this time to go trying to rifle through the ICD-10 coding list. So I just need to assign something that's accurate-ish so I can get on to the next patient. So there's a way to solve that, right? And so I think, this process should also be about getting at problems, and it should be consistent, right? Like there should be some organizational, written policy or procedure that physicians follow, that coders follow when it comes to the query process, including things like what are appropriate things for queries, what is an appropriate timeliness of response, what are the implications of non-response, and what are our expectations, right? Because I think I say this a lot of times on this podcast, the physicians are responsible for all of the coding information. The physicians are, quote, technically responsible for a lot of things, but they cede that to the organization, and therefore the organization has to determine who's responsible for each of these different steps and how those people are held responsible or accountable, excuse me, when those things aren't followed, right? And so prior to the change of these guidelines, one of the biggest things that I used to hear from physicians about is I would downcode a service because there was no family history or no social history. And let's say this was an initial hospital visit, and the physician would say, well, that's the responsibility of the medical assistant to document as part of the intake. And to the organization, we would say, well, I have to downcode the physician for its absence. It's up to you to determine if medical assistants consistently omit that information. What's that accountability? And I would say the same thing about query processes as well. It's who's responsible for supporting the provider in the right way to ensure accurate coding is taking place.
Yeah, and I would say the opposite part of that, Scott, what you were talking about points to, in my mind anyways, when there are actual coders inside of the practice or the organization. One of the things that I find with the providers I work with is a lot of individual private groups do not employ coders. So I get a lot of providers who are very frustrated. I'll sit with them, I talk with them, we talk about audit findings, we go through education. And just like you had said, Scott, they're incredibly frustrated that they don't have time for this. I had a physician one time tell me that in life, their goal is to be a good mother at home, to come in, be a good physician for their patients, and it's all just becoming too much. And one of the things that's really difficult to navigate in that situation is the fact that when there's not a coder, it is the provider's responsibility. One of the things that I've done, and it depends on the EMR system that you have with the group, but one of the things I've worked on to help alleviate some of these issues for the providers is have, for example, the IT department go in and not display in their pick list any unspecified laterality. So if they're looking for knee pain, for example, the other hard part is it's hard to tell if there's a bilateral option or they have to do right and left separately. I will give them some tips on that, but when they're searching in their mind, they're looking for the word bilateral and it often doesn't exist. They default to unspecified. So when you work with IT, you can sometimes have them hide those codes that we don't want the providers using so that it is easier as they're searching. Now, one of the other things, and Paul, I'm curious on your thoughts with this. One of the other things I'm dealing with some different clients that I have very strong feelings with what I'm seeing that the insurances are driving this selfishly from their perspective to maximize risk adjustment, but I'm seeing where insurances are denying for unspecified. So now with these clients that I have, we have the issue of the providers already feeling overburdened. We have issues with no coding staff there. It is not the billing team's responsibility to read every note and update the codes for the provider. And in addition to that, we're seeing an increase in denials at the same time.
Yeah, well, I'll speak to that last point and then make a larger point. Uh, of course, we're seeing an uptick in unspecified diagnosis code denials because that's what insurance companies do. I mean, we have a very large ICD-10 clinical modification in the United States because of our payer system. If you compare it to clinical modifications in other countries, Ours looks gargantuan by comparison. Uh, and that is all based on payer differentiation in the United States market. Now, I will say that Medicare did not help this in the first year after rolling out ICD 10 by saying close enough is good enough and setting the standard going forward, where close enough was good enough for but not explaining that it was only for the time being. And now, as we get deeper into not only commercial payer policies, but local coverage determinations, we find that close enough is inadequate and it's insufficient. So close enough is never good enough. This is not horseshoes. This is insurance reimbursement, and they're very cut and dry as far as what they'll pay. Now, as far as the query process, getting back to the query process for physicians, it's important for each side to understand their role. A coder does not have the role to explain coding to a physician. They do not want to be bothered by this. What they need to do is make certain that their query is fine-tuned to make certain that any modifications or any questions that are asked are getting to the most precise point in clinical language where a physician can assist them. And by the same token, it's not the coder's responsibility to suggest clinical modifications to documentation. A query is exactly that. A query is a question, and a query should be laser focused on exactly what information you are looking for. Now, I've always believed that the more queries you have, it should be directly proportional to the complexity of the type of medicine that happens in your practice. I would expect that there'd be a lot more queries in neurosurgery and spinal surgery than there would be in family practice, just based on the types of conditions that you see. No matter what your query process, it's very important that somewhere, some way, you have that query process documented and you have that query process laid out by some type of policy within your office to make certain that it follows a certain pathway to get the information that is required and is not leading the physician to modify things just for insurance reimbursement.
I'd like to follow up on that too. There's queries are specific actually. A HEMA puts out how to query and how to make sure that it's appropriate where you're not leading the physician. There's multiple choice answers. There's also possible yes or no, but you have to be careful with those. Those are only on occasion. I actually even teach a course on the art of the physician query, and I know I've podcasted on it. But physician queries, you can't make assumptions, especially as coders, especially as auditors, and to lead a physician one way or another, because that can get you into trouble. It's ultimately the physician's responsibility to do that. But here is also, and there's a pain point for a lot of coders, auditors, billers, is that when it gets excessive, as I mentioned before, and now you have a physician or a provider that's ignoring your query. So all of a sudden you have something sitting there. Your responsibility is to make sure that you get your claims out, get them processed as quickly as possible. And you send out a query because you're not sure what diagnosis to put on it based on what you're seeing. And so you queried a physician and you're hearing crickets. So then at that point, what do you do? Well, first of all, and I know this is going to sound obvious, is that there has to be a way to, first of all, have a policy, just kind of like what Paul and Scott were referring to. That's a written policy on how protocols, how workflows, how this is going to work, and what is the time frame the physician has to respond. And if they don't respond, then something isn't billed. You can't send something out going, well, the doctor didn't respond, so let's just slap this code on it so I can get something paid. That's the worst thing to do, because then at some point it's going to come back to get you, especially if it's inaccurate. The other thing, and I've seen this happen a lot, where the documentation and the diagnosis from the hospital admission and stay is different than what the doctor gives you, and it's for the same procedure and same stay, and all of a sudden you're putting something on there that isn't consistent, and now the payer sees that, especially Medicare. They'll see that inconsistency. So I'll put it back to the panel. One thing I do, and I'm pretty strict about this, if the physicians do not respond within a time period of 7 days, and that may be longer than you want to give them, but I'm looking at timelines for billing and sending out claims, then that's a negated record. They don't get to that, it's not billed. So is there anybody else that has a feeling on that? That's just my rule, but I want a response. And if you don't give a timeline or a deadline, I should say, then you're not going to get one sometimes.
So I think for me, what I would say is it needs to come down to a written policy within the organization. Um, you know, some organizations are going to look at it and they're going to say, depending on our participation agreement, we have to submit a claim to a commercial insurance company within 30 days. Now, obviously, the longer you allow a note to sit out there that is incomplete or is highly questionable, or there are elements that need to be properly addressed, the more time that goes by, the less likely you are to, in my humble opinion, be able to create a truly accurate depiction of what transpired during that encounter. So, I like the 7 days. But I also encourage folks to consider what are your time frames for being able to submit a claim to a commercial payer. One of the things that I would also be, cognizant of is that the the revenue cycle, especially if you have providers who are non-responsive or are very slow responders, your revenue cycle is going to suffer because of all of the delays and having to hold all of these claims, getting that money cycling and coming in as it's supposed to. You're going to start to see some of these gaps. And when providers start to wonder why they're not getting their full productivity, bonus, or they're not getting their quarterly bonus or whatever it may be, somebody in administration needs to sit down with them and help them understand until you get onto the same page with the rest of the team, your reimbursement is going to potentially suffer.
Well, and look at what happens if you have a surgery, Sean. All of a sudden, you don't get your query answered for that surgery. Patient comes in, let's say 10, 14 days later for a post op. The person who puts the charge in the computer doesn't see a surgery, so they bill it as a visit when it's actually a post op. And now you've got this vicious cycle because then, let's say after that visit, then the surgery finally gets put in, at maybe the 30-day
Oh,
point,
yeah.
and now you've got, inappropriate billing going out. There has to be a refund. It's a mess.
I think there's a
No,
couple things.
that's a great point. Go ahead, Scott.
Yeah, there's a couple things that I would add to the idea of a query process in general. Like a lot of these query processes are the byproduct or are currently done via like electronic communication tools that have either been created through the EMR or some other mechanism. And I think a couple of things I would say at a high level as it relates to the revenue cycle. Like if a provider is ignoring so many queries or not being refractory to responding to so many queries that it's having an appreciable impact on the revenue cycle, it's a bigger concern than strictly a query response process. I think one of the things that I found, in addition, through a well-refined query process, is a good mechanism to measure the alignment between the coder, or I'll say the querier, whoever that is, and the queryee, right? In this case, the provider. And so my hope is that, when you think about a query process, it goes beyond the fact that we're going to limit ourselves to the electronic tools that exist and contemplate the point at which you have a conversation with somebody, be it the provider to the coder or whoever's doing the query, about how to make sure there's alignment, right? Like, what is the coder seeing? What is the provider seeing? And I think, some of that arises out of the culture of organizational respect that you set, right? Like, I've worked with clients where people are, terrified about talking to the physician about a billing issue because they assume the physician's just going to kind of snap back that they don't know what they're talking about. And I've worked with organizations where, the physicians will talk about how much they appreciate the feedback they get on the little nuances and difficulties of coding that they don't necessarily want to be in the weeds on. So I think that the query process is one thing, but when we think about what makes it successful and what the end goal is, right? Like the end goal is accurate, complete documentation that's suitable for coding. And my hope is that when you contemplate a query process, you're going a bit beyond these one-off transactions and thinking about, if I'm querying the same provider about the same thing, how do I internalize that knowledge? How do we have conversations that align these individuals doing the querying outside of that sort of electronic exchange? I think because I can say personally, I'm not a physician. I'm not typically involved in that query process. I think we've all experienced electronic communication and how impersonal it can seem relative to an actual process to building a workflow that gets to consistent, correct action in a certain area that minimizes the need for queries in general.
So
Yeah.
go ahead, Stephanie.
All right. So I was going to touch base just on the environment that organizations or practices allow to exist surrounding the entire revenue cycle. If you think about it this way, a lot of times the provider's focus is going to be heavy clinical, our focus is going to be heavy compliance billing, right? But in reality, we don't have one without the other. Clinical plays a heavy role because without that piece, we don't have billable services. But one of the things that I find, and when I notice this shift in organizations, it's very obvious because when you have a situation where providers are allowed to rule the roost per se, and they're calling the shots, they are very moody, or Scott, like you were referencing there, when they have these anger responses towards the process, it's not helping anybody. And on top of it, when you have administration who allows those providers to dictate what we're doing on this side, that's when we often have stopgaps from a billing perspective. And I've worked in situations, for example, where an entire residency program was following faculty who had no respect for the revenue cycle and was allowing residents to not document just their notes in general for many, many months at a time. And on the compliance side, on the coding side, trying to keep revenue going, it was horrific because every week we're following up where there's no respect built between the two parts there because faculty was viewing it as a nuisance. And then on top of it, in that particular organization, the physicians and their moods were ruling everything that was happening. So at the end of the day, the groups are working against each other. So for me, when we talk about queries, when we talk about this entire process, when I see that clients have an issue here, I feel like the starting point has to be education. Um, Terry, to your point, when you're saying, too many queries are just going to sit there, they're not going to pay attention. Well, from our perspective, and I know it's easier for me to say because I'm a consultant coming in from the outside, which sometimes helps to have that perspective. But when I see this issue, we first need the buy in of administration to get them to understand why this isn't going to be optional. But then we have to sit with the providers and help them to understand what our environment is like. All of us have talked about the outcome of not sending out claims timely, inappropriate coding. And a lot of them, I find personally, when I talk with providers now, even just this year, they weren't even aware that things like diagnoses are now driving denials. So we need to help educate so they know why it's important and then move forward with queries with administration backing that those processes are not optional, basically.
And one of the things, so you bring up a very good points. A couple of things, right? So we're talking about evaluation and management services, and I want to go back for just a moment because E&M services have always been highly subjective, right? And Paul, you raised a point very, you know, uh, um, appropriately earlier when you were talking about, the clinical relevance and who should be making the decision for the code based on the complexity of the decision making, the medical necessity of the services. Terry, you and I always talk about medical. necessity, medical reasonableness, medical appropriateness, things of that nature. When the E&M codes changed, right, in 2021 for the office and other outpatient setting, we got away from the quantification and we went more towards the defining an E&M, especially the history and examination, by what is considered medically appropriate and reasonable. And I try to explain to people all the time that if you thought E&M codes were highly subjective using 95 and 97 guidelines, it's even more subjective in my opinion now. I'm getting ready next week. Next Monday, I have to go to a federal trial. Um, I can't say where it is at this point until the trial's over, but they're going after this provider for inappropriate billing of E&M codes and saying that the services were overbilled. And what's really funny is they keep saying, now remember, these are services rendered in 2021 and after. And the government keeps saying that they didn't have 15 minutes of time documented to support the level of service. Well, it's not 15 minutes of time. It's a time range. It is a time range, right? We're talking for 99213. What is required? 20 to 29 minutes, 20 to 29 minutes of total time on the date of service that a face-to-face encounter takes place. That 15 minutes is irrelevant.
Sean, we're even seeing references to time and services that go back prior to that. Where did they say, well, this doesn't reflect, there's no time documentation. It's like, well, that's not
That's
how
right.
that worked then.
That's right.
Well, I think
there
it's
needs to
because
be
the Go
something
ahead,
a
Paul.
little bit deeper.
Well,
But
the problem is
real quick,
because
Terry,
that's how
yeah,
they price it. You remember when you look in
right.
the pricing for this, when they look at how to base the RVUs for E&M, they base it on time, and it doesn't match the time that's in CPT all the time. It's
It never did.
insane. It never did.
Yeah.
And so, but then they give us two sets of medical decision making or time, and then here's the other thing,
Yep.
and I'm sorry to interrupt you guys, but this is the one thing that drives me crazy. Remember when they said, I think it was 2000, correct me if I'm wrong, Stephanie, I know you know this, 2018 or 19, where they now said that you don't have to have the physician do some of the elements of the history and the beginning of the exam, as long as it's in there. The clinical staff can also make some of that, can also contribute to that. But you're not allowed to use their information if they're the ones documenting, if it's a time-based code. So they allow the clinical staff now to save the doctor's time, but if they save the doctor's time, the doctor can't use the time. Did you get that tongue twister? So it's funny
Yeah.
to me because
Yep.
as soon as we take one step forward, they shove
Hmm.
us, five
I,
steps backwards.
I
Well,
will
the
say,
point,
at the very least that the physician time file that's in the physician Medicare physician fee schedule for the year has been calibrated to the new code sets across every single E&M code. Where it used to be, when you got to the higher levels of code, there was this enormous difference between CPT and Medicare. There's now less of a difference there. It's actually, some of them are right on the nose when you're getting to all the way up to level 4 in some cases. So it has been normalized to an extent, but again, it's medical decision making or time, and the complexity has got to be there in order to meet either one.
But then we get these weird things, Paul, in the hospital visits where, what did the shared visits say, the most recent? And actually, they commented, I think it was number G in this last transmittal, that said that, they're going to look at time based codes and see if you're accurate and if it's appropriate. But the one thing they were saying is that the doctor has to, at least whoever's billing it out, if they're on a shared or split visit, they have to meet in its entirety one of the elements necessary to bill out the service, history exam or medical decision making. Well, we don't level a code by history and exam anymore. So what are they saying? And the other thing, there's no guidelines for history and exam anymore. Not that they disappeared as far as we don't have them. It's just we don't use them to level the code. There's a difference, everybody, on that. So,
Right.
you know,
So,
it's
and that's what
weird.
I was gonna bring up, right? So the question that I continuously get is, well, how do you define medically appropriate history and exam?
How do
Well,
you?
it's subjective. Now I can tell you what the 2021 E&M guidelines for office and outpatient history and exam say, and it's, quote, "Medically appropriate means that the physician or other qualified healthcare professional reporting the E&M determines the nature and extent of any history or exam for a particular service." End quote.
Doctors are doing
I
a
mean,
party on this. It's terrible. It's absolutely
I mean,
terrible.
thank you, AMA, for making things more complicated than they needed to be. Listen, when people say to me, Sean, how do I explain to my provider what is, a medically appropriate history and exam? My response to them is, tell them to use their clinical judgment. Tell them to make a determination based upon the patient's presenting problems, symptoms, signs, past social, family history, and make a determination as to what are the most appropriate questions, what are the most appropriate elements of an examination to perform. But remember, we don't quantify those in any way because they don't ultimately lead to a level of service.
They just have
What
to be
leads
there
to a
to get
level
the
of
service.
service
Yeah.
is what leads to a level of service is the medical decision making or time.
But
And
now in
again,
saying that,
time.
now
Yeah. Go
here's where
ahead.
we get just to pivot to our next topic when we're talking about, so first we're talking about querying, what are the liberties the staff can take. Now we get into upcoding or downcoding. Let's say you're a certified coder, you're a certified auditor, and you have a document that the doctor, let's say, reported 99214, and the coder feels that it's either a 99213 or 215. Well, are they allowed to change the code based on how they subjectively audited the service? Now, I'm conservative in my auditing approach. Some people might not be. You can have one claim and everybody could audit it differently when it comes to E&M. It's crazy. Say, well, I'm going to count, the doctor saying continue meds as medical decision make or as prescription drug management. I'm like, not me. I want to see a little bit of detail on what that's for. So you have this subjectivity, but here's my thing on this, and then I'll ask the panel to join in. When it comes to upcoding or downcoding, and upcoding is a terrible word. If you've ever been in an arbitration, lawyers love that term, upcoding. They're just like, okay, so you were upcoding. They also like the term cheat sheets, never use that. So it's like when you look at that, if you're going to take that, and I don't want to say liberty, but if you're going to take that initiative to make that decision, you have to have physician agreement, in my opinion. Because who's ultimately responsible for that claim, regardless of your certification or what you think that is, the doctor, the provider has to be on board with that change, and it should be in writing somewhere that they're going to accept it. The down coding is easier to swallow, but for the coder anyway, but the up coding makes me nervous. If a doctor truly thinks that something is not worth a high risk and puts it in his moderate risk patient, and they base their service on a level 4 and all the medical decision making goes with that, and you as a coder say, yeah, but this could support level 5, who on the panel would allow people that you work with to upcode without physician approval?
Well, let me before we go to asking that question, let me give you a real world scenario that just happened. So, I have a physician client who has a staff member for years reviewing their documentation, and unbeknownst to the provider, that individual was taking liberties with adjusting the levels of service and going into the provider's documentation and making modifications to some of the words in the documentation itself. Now, the provider was investigated by the Department of Justice. And the Department of Justice said, something's fishy here. This is not a civil matter. We think it's a criminal matter. Well, the doctor was placed under criminal investigation, but the staff member who took, to use Terry's word, the liberties of adjusting the codes was issued a grand jury subpoena. And she was commanded to appear before the grand jury to answer questions. Well, guess what? The provider, with the help of their legal counsel and myself, was able to engage with the prosecutors to help them understand that, hey, the doctor did their job. The doctor had no earthly idea that any of this was going on. Here's the proof. Here's an audit trail to show where the provider entered all of their information and where this individual went behind them at a much later date and started adjusting things. So now the criminal investigation was shut down for all intents and purposes, right? They still wanted documentation to clear the physician. But guess who now became the target of the investigation? The individual who is changing all the codes and who's changing all of the words. Folks, I talk about risk tolerance all the time. I am not a person who's willing to accept or assume a whole lot of risk for things that I shouldn't be sticking my nose into. At the end of the day, a coder's job is to review the documentation created by a provider, compare that to the CPT coder codes, the ICD coder codes, the modifiers that are selected, and then make a determination as to whether or not the claim going out the door is going to be clean. And if not, then the query process that we were previously talking about should be taking place. The same thing for an auditor. I get so aggravated when I hear a coder or an auditor say to me, well, I took anatomy and physiology. No, you didn't. No, you
Well,
didn't.
they may have.
Unless you can show me a college level course that you took anatomy and physiology, what you get going through the preparation to prepare for the CPC exam is not anatomy and physiology. I am sorry to disappoint you.
I
have an
doctorate.
RN.
I played
Oh,
hours.
now you all want to chime in.
I
Yeah,
played,
I know,
I
right?
played
One at a
hours
time.
of the board game Operation throughout my childhood.
And he was awake, right? Right, Scott?
Yes.
Your patient was wide awake.
I have an RN, and
All right,
I
Stephanie.
still make sure that the physician is given the ultimate decision. I mean, clinical information aside or background aside, it's their responsibility, and they're the ones that are ultimately going to get it if they do it wrong. Stephanie, sorry, go ahead.
No, that's okay. So I think this is all pointing to, the reality of the situation if we think about this for a little bit here. Realistically, how many times do we walk into a client and the provider wants to be hands off? There's so many times, like with those education sessions, they're frustrated they have to meet with me. They're frustrated they have to hear about this. They don't want anything to do with it. But when we think about it, like we've been saying, this all comes back to the provider at the end of the day. If there's issues happening between the documentation and the code selection. So, I say that because the reality of what we see going into organizations that have coders is that queries are not happening as often as we're talking about here. So if a code is being changed, it's known and agreed upon previously, typically by the providers, that if something's changed, their staff is trained, they have the knowledge, and it's just going out the door after the codes are changed. Now, that, obviously can cause issues. And one of the things as well, and I think we lightly touched on this today too, we also have to think about the staff involved in the revenue process. So when we talk about a coder, this is somebody who is trained. This is not somebody who's just been in the industry in one practice for 20 years, who's never had outside input or education, that is just aware of what CPT codes are. We're talking about actual trained staff that have the oversight, that have the quality reviews being done, that have the continuing education. And what I find is that providers still try to be hands off when we have billers in the mix here. So we don't have people who have the complete knowledge from a coding perspective. They're aware of different claim edits, for example. They're not trained in coding. Their job is not to code every encounter, but yet the providers are still wanting to be hands off. So, one of the extreme examples that I'll throw out here and then hand this over to Scott or Paul. One of the examples I had a couple years back, I went in to start an audit with a smaller practice, and it was a private practice and the billing was outsourced, and the physician owner quickly let me know that I needed to talk with so and so at the billing company. To me, that was a little strange because when I do audits, I work closely with either practice administration, or if they don't have it, typically the physician owner. So I reach out to the biller for all of this and quickly find out that this provider is just completely hands off. They want nothing to do with the coding or the billing process. But as a part of the contract, they're submitting all the codes over for entry. Well, I met with the lead biller and did my typical kickoff call like I would with a practice administrator, start, digging in, asking questions, and come to find out this biller is making all kinds of coding changes because she felt like she was saving herself by not putting her name on a claim with services she felt were not supported. Well, what was ultimately happening was this physician felt level 5 services were supported on a high volume basis. She was just automatically downcoding to a level 4. And then when I conduct my audit, knowing this is happening, I go in and even the level 4 services were not supported. So now we have a physician on the line for claims that aren't right. We also have a biller going against their contract and just changing codes because they felt like it was safer. Paul or Scott, you want to jump in there?
I've seen similar things. One of the things that I was going to say is with respect to E&M code changes. I've worked with a group where somebody in the billing department, similar to what you were saying, basically decided of their own volition that they were going to change a bunch of the codes that were being billed by the providers, and in most cases, they were lowering them. In this case, it came to the front of our attention as part of as part, excuse me, of a revenue cycle review, because the amount of revenue that the practice was receiving was declining materially. And one of the reasons was that virtually all of the things that they used to bill as fours and fives were being downcoded to fours and threes. Whether it's appropriate or not is secondary to the fact that the providers had no visibility or insight into the fact that it was happening. Now, I've worked with other groups where they require, as a part of their policy, that the physician must personally bless any changes made to a E&M code prior to it being made, regardless of whether or not that's what the physician really wants. And so these queries get stacked up. And if the physician ultimately disagrees, I think it actually goes to like a 3-person committee or something to resolve. And so, I think the one thing I would say about this at a high level is, you know, other than professional liability, as a physician, your biggest exposure probably has to do with the fact that you're stipulating when you send these codes in that they are accurate and that they're going to be reviewed by payers, including the government. And I've been all over the map with the providers I've worked with in the past, from providers who get very deep in the weeds with knowledge of coding, specifically E&M coding, to providers where I'll mention in an education session 99214, and they don't even know what that is. And so, as a provider, you can be anywhere on that spectrum, in my view. But if you're somebody who doesn't want to be actively involved in the coding process, then it's particularly incumbent upon you that you hire people that know what they're doing, and or you validate that the work is being done correctly through things such as external audit, right? Because if you don't want to have your hands elbow deep into it, like, I kind of respect that, right? Like, that's one of the things I do for a living, and sometimes I wonder if I want to have my hands elbow deep into it. But you do need to understand that your livelihood is potentially going to be imperiled by these decisions that are being made as they happen around you, right? And so, similar to Terry, I'm very reluctant to bless a query process or to bless any process where somebody is upcoding provider documentation without that provider signing off on that change, or raising the level of service. But there's also scenarios where the provider will say, look, I don't know anything about this. Your work is being validated. I understand what you're doing. If you believe it's this level, and then you've got some other second process in there to validate that. I just think whatever it is, what's important, similar to what we talked about before, is that there's organizational buy-in and there is a defined process, that there aren't people who are making rogue decisions about the E&M codes that are being billed to the positive or the negative. And the physician should be able to articulate whatever that E&M coding policy is, or have signed off on it, because it's um, their liability that's being tested when these claims are being filed.
One thing that I'm finding with clients, so I had a particular client group that was oncology and could not get anywhere with them. They thought everything that left their office, from telehealth to in person, level 5, straight across the board. Didn't matter. It was all 5, 5, 5, 5. And as I'm doing this audit, and I audited 300 E&M services, new and established patients, you name it. And oh my gosh, they failed their audit by 80%. And I said, this is a level 3, this is a level 4. There were level 5s that were clearly appropriate. And they kept looking at it of the complexity of the patient. Well, this patient's on chemo, or this patient's doing this, or this cancer patient. I'm like, you're oncology. All your patients are cancer patients, but I appreciate what you're saying. But have you looked at the new rules? What is the complexity of problems addressed? And I said, you have, right. And I pulled up the exact record and said, okay, you have the patients being followed for their congestive heart failure by their cardiologist. They're being followed for their chronic pain by their rheumatologist. They're followed by this, by their orthopedic. I said, and you even put in here that in your note, patient doing much better today, ending chemo, and patient may, blah, 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 start on this or whatever. And patient doesn't need to be seen for another 3 months. Where is the high risk here? Not today's visit. And it's very frustrating when people go back to what we used to consider when we were leveling a code, the overall complexity of the patient. But now we look at the complexity and the risk of today's visit. And you have to know that difference. If you don't, you're going to absolutely overcode, because you can have a complex patient with multiple problems that today is doing better. I mean, today they're a low level complex patient, or low level risk patient, I should say, or complex patient from a medical decision making standpoint. And then the doctor says, well, I'm just going to time everything then and put 40 minutes, because I usually spend that kind of time talking to them. And I'm like, oh, so it's almost sometimes talking to a brick wall. So here's the moral of that story quickly. I know we're running out of time, but I had to say, you know what, I can't deal with you guys anymore. 80% fail in an audit. I've been doing this for over a year and you're not listening. So I'm going to say you're going to need to find a different consultant. No, Terry, please don't. No, I just won't deal with it anymore, because now I feel like there's some self-reporting here. You're overcoding blatantly. So we parted ways. 3 months later, they get a TPE audit. They also got a UPIC audit for something 5 years before. And they're like, Terry, can you help us? I'm like, I don't think so. And they're like, please. And I'm just like, well, my fees are tripled. I'm kidding. But I'm just saying that at this point, it's like banging your head against the wall until all of a sudden somebody comes knocking and says, hey, you're overcoding, you're overbilling. This is really a problem. I see somebody put in there, isn't there still a bell curve to overall E&M's build? So let me speak to the bell curve a little bit. And anybody can disagree with this if they want, but this is what I see with bell curves.
I
Bell,
disagree.
Yeah, bell curves are. I knew Sean would. He's like, I disagree with everything, Terry. No, but bell curves to me are are benchmarks. There's something you need to look at, and if you see anything that goes outside your bell curve or that is concerning from your bell curve standpoint, because some specialties are going to be a lot higher in what they bill as far as levels of service than others. That's no question. And oncology would probably be one of them, but it doesn't mean that you automatically assume that. So I like looking at bell curves just to make
Yeah.
sure we're seeing where everybody is from a benchmark perspective. But I don't look at that as that's the holy grail that you have to hit certain
Yeah.
percentages.
Yeah.
Paul, I
Your
know you've seen that.
your bell curve is not today and forever after. Your bell curve is your audit plan. I mean, that's the beginning of your audit plan. You're looking at where you are in current state and whether that's correct or not. So
Well,
let's not just rely on the bell curve saying here, this is the
well,
average. Sometimes sometimes you're below, sometimes you're
Sometimes you're above.
Well, and
Yeah,
above.
it's
so
just a
so
tool of risk,
it
really.
is. It is. And if you see a lightning bolt instead of a bell curve, that's where you want to go, wait, wait, wait.
yeah. So listen, physician distribution analyses are what we're talking about. Bell curves are unreliable in the current day because most of the data that's available is about 2 years old. So it's unreliable. I think if you are looking for something that is reliable, you could use programs like Compliance Risk Analyzer (CRA), where you upload your utilization reports, and through an augmented intelligence, as you feed it more information, it builds off of a predictive analytic model, and it will actually create your bell curves for you based on the most current data that's available. But your trending reports will be based on your own internal utilizations, which I think is the easiest way excuse me, to identify whether or not you all are at target. It's important to understand not only what you're at target for from a high risk overcoding standpoint, but it's also critical to be able to understand what your actual financial loss could be based on systemic undercoding of your services. So, it goes both ways. Um, at the end of the day, I think, what folks need to take into consideration is something very simple. Every single one of us is referred to as an entity in healthcare. Scott, Terry, Stephanie, Paul, myself, we are all considered entities, just like Betty Hovey and Brenda Bow and Samantha Patterson and Lisa Chavez and, Annette and Lisa and everyone who's joining us today, right? We are all entities, which means we are ultimately responsible for the pile of dung that we step in that we can't pull our boot out of. So be careful of where you step and how deep you step into it. Because at the end of the day, when you start looking at who can be sanctioned, who can be excluded, who can be civilly or criminally prosecuted, it's each and every single one of us who has assumed the liability of performing services above and beyond our pay grade. At the end of the day, allow clinicians to do the clinical work. If a physician says, this is the level of service that I want billed, and you disagree with them, query it. But at the end of the day, if the physician says this is the level that stands, that's the level that should be billed. Now, if you have concerns about that, document it. If you have a compliance officer, get it to your compliance officer. If you don't have a compliance officer, document it in your file. And that way, God forbid, if something happens down the road and somebody says, hey, Paul Spencer, you're the certified coder or you're the certified auditor. Why didn't you, tell the physician what they were doing was wrong? Or why didn't you make changes? Now you pull out your little book and you say, on this date at this time, I queried the provider. The provider told me you're not the physician. I'm the physician. That's the level that stands. And that's the end of it. In this industry, unfortunately, you are guilty until you're able to prove yourself innocent. And that's not how the criminal justice system works, but that's how it plays out. I agree with you, Lisa, 100%. Code as if we are testifying in court. Absolutely. I couldn't have said it any better. All right. That's going to wrap up this episode of the Compliance Guy Monday Coding and Compliance Roundtable. It's great to be back with everybody. We were a little bit concerned because the comments were just not appearing for some reason in our chat. But then I came over onto LinkedIn and I saw a ton of messages that are or have been posted there. So we'll have to get with our provider for our platform to figure out why we're not seeing all of the posts. Anyways, thank you all so much for tuning in, logging on, and hanging out with us. As I said, we're excited to be back. We will be back again. Not next week, because I will be testifying in a federal criminal trial next Monday. So I know Terry and I will be back on Tuesday for our hashtag Terry Tuesday episode. We'll be back the week after next, unless I can convince my panel to do a Wednesday coding and compliance roundtable. Well, no, we can't do Wednesday either. We'll have to talk about it. Anyways, we'll plan to be back real soon. All right. On behalf of Scott Kraft, Terry Fletcher, Stephanie Howard, Paul Spencer, thank you all so much for being a part of today's episode. We'll see you soon.